Welcome everyone to our inaugural session of Medicine Grand Rounds for the 2021-2022 academic year. We have a very packed list of speakers today because of our, we have 5 awardees that we'll be honoring. And so I think I'll go ahead and get started. People will be signing in as we go. Today, we are celebrating our initial group of Diversity Academic Development Scholar awardees. And they will be giving 10-minute presentations to introduce themselves and their areas of research to the audience. The Diversity Academic Development Scholar Awards were established in 2020, and they're really an initiative by the Department of Medicine to improve the DEI efforts in terms of faculty development in the Department of Medicine. And these individuals were chosen. They received $50,000 a year times 2 years as awardees to promote and foster their transition from being a senior fellow acting instructor onto junior faculty. And this year we have 5 awardees. The 5 awardees are Crystal Brown from Division of Pulmonary Critical Care and Sleep Medicine, Chase Cannon from the Division of Allergy and Infectious Diseases, Erik Kimball from the Divisions of Hematology and Medical Oncology, Helen Stankiewicz from the Division of Allergy and Infectious Diseases, and Kennedy Ukadike from the Division of Rheumatology. Please, if you have any questions that you would like to pose to the speakers, please put them in the chat. Dr. Tess King, who is the Chief Resident at the University of Washington Medical Center, will be monitoring the chat, and she can pose questions to the speakers at the end of the overall presentations. So our first speaker will be Dr. Crystal Brown. Dr. Brown is in the Division of Pulmonary and Critical Care and Sleep Medicine. Thank you, Dr. Brown.
Thank you very much for the introduction. And I will, okay. Thank you again for the introduction and for this award. I'm very honored and grateful. So I'm going to be speaking about racial inequities in serious illness and at end of life. I have no financial conflicts of interest. So a little bit about me. I am a pulmonary and critical care physician. I have a master's in bioethics, and I'm also an ethics consultant at Harborview, although this work has been put on the back burner in order for me to be able to pursue my research interests. And I have the support of a fantastic group of mentors led by my primary mentor, Dr. Randy Curtis, and also Drs. Young, Dole, Rosenberg, and Engelberg. So I'm going to start with a little bit of background information on racial inequities in palliative and end-of-life healthcare. So in the last 6 months of life, compared to white patients, racially marginalized patients are more likely to visit the emergency department, to become hospitalized. And when hospitalized, they have longer lengths of stay. They're more likely to receive higher intensity interventions, such as mechanical ventilation and CPR. And they're also more likely to die in hospital. Racially marginalized patients are less likely to have a DNR, to withdraw life-sustaining therapies, and to receive palliative care. They're also less likely to enroll in hospice, and when enrolled in hospice, they have shorter lengths of stay. And Black patients in particular are more likely to disenroll or unenroll from hospice to pursue higher intensity care. These differences in healthcare utilization at the end of life has been attributed to many factors, such as preference, mistrust, acculturation, religion and spirituality, and health literacy. And these factors have been targeted by many interventions, but without the hope for long-lasting positive impact. And this inequity in end-of-life healthcare utilization is important because it results in racially marginalized patients experiencing poor quality end of life at the end of their lives, poor quality of life. And so my perspective on this is that in palliative care research, the stressors of being racially marginalized in healthcare is under-investigated. And what I mean by that is exploring patient experiences around healthcare discrimination and bias. So my research question is, does healthcare discrimination impact the way patients communicate with their doctors and nurses and ultimately affect the decisions that they make for themselves? I hypothesize that experiencing healthcare discrimination and bias contributes to poor patient-clinician communication and impacts decision-making during serious illness and ultimately affects the type of care that patients receive at end of life. I also anticipate that an existing intervention called PRISM, or the Promoting Resilience and Stress Management Program, can be tailored to help racially marginalized patients manage the distress of discrimination and improve patient-clinician communication. So to perform this work as both framework and processes, I'm using a pragmatic form of critical race theory called public health critical race praxis, or PHCRP. PHCRP has 4 focus areas, and within those focus areas, 10 principles based off of CRT tenets. The one principle that's actually permeated throughout all 4 focus areas is race consciousness. And race consciousness is the explicit understanding of how race and racism affects the daily lives of persons of color, even in the healthcare system. So I'll talk a little bit about how each focus area is informing my work, and then later on give examples of a few of the principles. So the first focus area, focus 1, contemporary patterns of racial relations. So this focus area will allow me to investigate how my work is impacted against the backdrop of current events, such as the resurgence of the Black Lives Matter movement and the COVID-19 pandemic, especially in light of the disproportionate deaths of Black and Brown patients and the spotlight on inequitable resource allocation decisions. Number 2, knowledge production. This focus area will allow me to better understand how prior research in palliative care continues to stigmatize marginalized communities and perpetuate inequities. And number 3, conceptualization and measurement. This area will allow me to explore if my proposed measures, such as the one I'm using for resilience, can account for and capture the sequelae of healthcare racism. And 4, action, ensuring that my work benefits racially marginalized patients and helps disrupt inequity. So I'm currently enrolling a prospective cohort of patients with serious illness to examine associations between discrimination, communication, mistrust, and healthcare utilization. Thus far, my patients are so far Black men with a little bit over high school level of education and levels of income and wealth corresponding with poor levels of health. They're also reporting high levels of discrimination and microaggressions in the healthcare setting, as well as high levels of race-based medical mistrust. I'm also performing semi-structured interviews with a sub-cohort of participants to dive deeper into understanding perspectives around how discrimination affects the way patients communicate with their clinicians. So to illustrate some of the themes that are beginning to manifest in these interviews, I'll introduce 3 PHCRP principles. First, voice. The principle of voice states that the perspectives of racially marginalized patients should be prioritized, or what's called centering the margins. So during interviews, some patients do report feeling that their concerns and perspectives are not respected or taken seriously by healthcare professionals. Number 2, ordinariness. So the principle ordinariness states that racism is present in the everyday life of racially minoritized patients, even in healthcare settings. And while participants are not using the word ordinariness, some participants do feel that racism is ubiquitous within the healthcare system, if not explicitly, then implicitly. And lastly, race is a social construct. But some participants describe racial anxiety when interacting with doctors and nurses who don't look like them, and also express fear around stereotype threat that does impact the way that patients talk with their treating clinicians. So during these interviews, I'm also obtaining feedback on a modified version of an existing patient-facing intervention to improve resilience and patient-clinician communication. So the Promoting Resilience and Stress Management Program, or PRISM, is a program designed to improve resilience in patients with serious illness. And I'm currently working on adapting it for racially marginalized patients with serious illness experiencing healthcare discrimination, or PRISM-RD. And PRISM consists of 5 one-on-one sessions, with each session targeting a teachable resilience skill. And what interviewing so far are reporting is that they are open to a modified version of this program to help facilitate conversations with their doctors about discrimination and bias. So the goal of this work is to decrease a disproportionately high burden of poor quality care and poor quality of life that's experienced by racially minoritized patients and help facilitate goal concordant care, and to maximize the impact of this work by incorporating race consciousness and critical race theory. So in the near future, I hope to also elicit clinician perspectives on perceived acceptability and utility of the PRISM-RD program, and to perform a pilot randomized trial of the modified PRISM program as well. I also will compare quality of patient-clinician conversations between patients who have and have not participated in PRISM. So in conclusion, so far, racially marginalized patients at UW Medicine are reporting high levels of race-based mistrust and healthcare discrimination. They're also reporting that they're open to participating in a program that helps facilitate conversations with clinicians about perceived discrimination and bias. And this research is ongoing, and hopefully I'll have more to report soon. So thank you very much for having me.
Thank you, Dr. Brown. Once again, I remind people, if they have questions, please put them in the chat and we'll try to address some of those questions at the end of the 5 presentations. But we'll move on now in the interest of, because we have 5 presenters. And our next presenter will be Dr. Chase Cannon. Dr. Cannon is in the Division of Allergy and Infectious Diseases. So I turn it over to Dr. Cannon.
All right, hello everyone. Thank you for the opportunity to speak today, along with my fellow DATSA recipients. Congratulations to you all. So as Conrad said, like Helen, I'm in the Division of Allergy Infectious Diseases and now starting my second year as junior faculty. I don't have any disclosures to report. So just to tell you a little bit about me and my background, I was born and raised in Texas, grew up on Mexican and Tex-Mex food, which I sorely miss. And if anybody knows where to get good breakfast tacos, please let me know. I attended medical school at UT Southwestern, and that was really where I started to kind of understand the differential impact of HIV on populations, including racial ethnic minorities and immigrants. So from there, I went to Louisiana for medicine residency at Tulane, and I was pleasantly overwhelmed by the food scene there as well. But training was a challenge, to say the least. The zip code around our main hospital in New Orleans had some of the highest HIV incidence rates in the country. And I think, the providers do all they can there, but the public health infrastructure was lacking. And so that brought me to UW for ID training, primarily because of the robust public health system here and its connection to academic medicine. So I finished a fellowship and an MPH in Epi here last year. My primary career and research mentor is Matthew Golden here in the Division of AID, and he's also the director of the Public Health Seattle King County HIV/STD Division. Countless others in the division have also lent me their ears and advice over the years, and I'm very grateful for that. I did submit a K-23 to the National Institutes of Mental Health earlier this year, and other mentors on that team include Ariana Means in the Department of Global Health, Ruan Barnabas, who has appointments in both DOM and the Department of Global Health, Jane Simone, who's in Department of Psychology and Global Health, and then Jim Hughes in Biostatistics. My primary clinical practice is at Harborview, where in addition to inpatient time, I have 2 outpatient clinics at Madison and Max. Occasionally, I work in the public health sexual health clinic as well at NJB. And I think maybe apparent from these sites that my clinical interests lie within HIV and sexually transmitted infection care and prevention, particularly syphilis. My research interests are related to these and include thinking about how we can expand access to preventative services, including pre-exposure prophylaxis or PrEP for HIV. And along with this, how we can accommodate high quality and appropriate testing for HIV and STIs outside of clinic settings. And last, I'm also interested in syphilis epidemiology and sort of better understanding clinical diagnosis using tools that we already have at our disposal. So what I'm going to share with you today is the primary research project upon which my K application was based. Many of you may know that HIV PrEP is highly effective on both the individual and the population level, but uptake in populations that need it has still been low and discontinuation rates are high. One reason for this is because guidelines recommend, that persons on PrEP be monitored every 3 months with labs, and this can be burdensome both to the patient and stretch the operational capacity of clinics, particularly during the COVID era. We've seen this. Home-based services where a person can follow up remotely and collect their own monitoring samples from home could be a solution for this problem. But there's no official guidance on how to do this. And the main limitations so far have been the type of collection method and that not all programs are able to run the appropriate tests. So our question is whether home-based PrEP monitoring could allow more people to stay on PrEP for longer. However, before we can answer that question, we needed to determine if patients were even interested in this option, and if so, if they could do it. So in 2020, we initiated the what I call Hot for PrEP study, which stands for Home Option Testing for PrEP, which is an interrelated series of studies to answer these questions. The pilot study, which I'll discuss results for today, evaluated acceptability and feasibility of self-collecting blood samples and the accuracy of these for PrEP tests. And the second component is an RCT that I'll mention a little bit later. So our pilot study had 2 components. The first was to ask PrEP patients in the public health sexual health clinic whether they had interest in self-collecting samples and in home-based services. The second component was to ask patients to self-collect blood samples, and then we compared the results of these for PrEP monitoring tests to a gold standard, which were clinical samples that were obtained by venipuncture. So this study involved the use of a device that was created by Tasso, which is a Seattle-based biotech company that allows one to collect capillary blood from the upper arm without needing to access a vein or stick the finger. And you see a picture there of the device on me as I was trying it out. We enrolled a mix of patients to ensure that we had a substantial number of people who were on PrEP and enough positive and negative samples for each type of test to do comparisons. And then the patients were trained on how to use the device, they performed the collections, and then completed surveys afterward. So I'll first discuss the results of the lab comparisons. So we recruited 166 people, and 48 of those were in person. There were a few limitations because this was sort of done during initial COVID restrictions. And 48 of those people completed the self-collections. You can see the demographic breakdowns here. Most were on PrEP, and over a third reported a prior history of syphilis. And that really has implications on which test is necessary for diagnosing new syphilis infections in this group of patients. The bottom left panel is a 2x2 figure showing the results for HIV antigen antibody EIA testing. So we performed 36 tests on paired samples, and the negative and positive percent agreement were both 100%. And on the bottom right panel, we see results for paired qualitative RPR tests. And similarly, the positive percent agreement was 100%, whereas the negative was slightly lower at about 95%, but still pretty good. I'm not showing you the quantitative RPR values here, but agreement for those was also high. And then paired creatinine results were positively correlated with clinical samples being on average about 0.05 milligrams per deciliter higher than self-collected samples. So for the more qualitative part of the study, most patients expressed that they were interested in self-collecting specimens at home during COVID restrictions and afterward if they end anytime soon. And they said that they preferred to do this over coming into clinic for a blood draw. A little under half felt that this home option could increase their likelihood of staying on PrEP. And when we asked what concerns they had about the process after they collected blood, a few people identified that the wait time, which is about 3 to 5 minutes, was an issue for them. Some said the stability of samples or the potential that samples could be lost in the postal mail. So all things that we should take into consideration. So what does this all mean? I think my takeaways were that interest in home-based services is high, and that self-collection of blood specimens for PrEP is feasible and acceptable, and that the results of laboratory-based PrEP monitoring tests show good agreement and also accuracy. One issue we did encounter was with the volume of some specimens being inadequate for all of the tests that we wanted, and so we're working on rectifying that. Nevertheless, I think with refinement, the Tasso devices could be a useful component of home sampling kits for people on PrEP, and that this could meet a growing need for screening increasing numbers of people on PrEP and simultaneously unburden our healthcare system that really has limited capacity right now to accommodate all of the patients who need quarterly in-person visits. So what's next for me? We plan to launch a hybrid randomized control trial to implement this home-based monitoring system as part of federal ending the HIV epidemic initiatives with public health. And this should begin in the coming weeks. And then I'll also be resubmitting my K-23 with some revisions. And then for the long term, I see myself as a clinician scientist focused on domestic HIV and STI prevention and working sort of at the intersection of academics and public health practice. My goal, perhaps at the associate professor point in my career, would be to lead an HIV STI division of a public health department in the South, where there certainly remains great need. So in conclusion, I'd like to thank Department of Medicine for this award, Anna Wald, our esteemed division head, Matt Golden, for all of his sage advice over the years, and all of the people who continue to make this research possible. And I'm reminded, as you can see in this quote here from one of our participants, that they really are appreciative of our work, and that pushes me every day to continue working with them. So this is exciting work, and I'm happy to continue. My email's here if you have any questions. Thank you very much.
Thank you, Chase. And I remind the audience that if you have questions for Chase or any of the speakers, please put it in the chat. Dr. Tess King will be monitoring the chat and can ask some of those questions at the end, at the conclusion of the 5 speakers' talks. Moving on, we'll go to our third award winner, and that is Dr. Erik Kimball. And Dr. Kimball is in the divisions of hematology and also medical oncology, and he's based at the Fred Hutch. So Dr. Kimball, the podium is yours.
Thank you so much. And thank you to the Department of Medicine for allowing me to participate and awarding this Diversity Academic Scholar Award to allow me to continue my research efforts and development. So a little bit of background about myself. I grew up in Los Angeles. My parents, I grew up in Los Angeles as a biracial ethnic minority. My mother is a Mexican immigrant, first generation, and my father is Black and grew up in a segregated small town in Texas. Throughout my trajectory, I've kind of traveled all over North America. I received my medical degree from the Universidad de Guadalajara in Mexico, where I lived for about 10, 11 years. In my final couple of years of medical school is when I first developed my interest in translational science, developing PCR protocols for respiratory viral pathogens in hospitalized children. I completed 2 years of internal medicine residency training at the Hospital Civil de Guadalajara in Mexico, and subsequently pursued training at the University of Miami, looking for opportunities in translational hematology. My first primary research mentor was Dr. Krishna Kamanduri, and together we worked on characterizing T-cell responses to CMV in the post-transplant setting. It was this work in T-cell immunology that really drove my interest in CAR T-cell therapy, and I was fortunate to match here at the University of Washington Fred Hutchinson Cancer Research Center. So I've been blessed with a fantastic mentorship team, which is comprised of Dr. Cameron Turtle, who's my primary research mentor, Johnny Orozco, who's my faculty advisor, and Janice Hapquist, who's my long-term career mentor. And so I currently work on developing chimeric antigen receptor T-cell therapies for hematologic malignancies. And just as a brief overview, CAR T-cell therapy involves the generation of antigen-specific T-cells at the discretion of the investigator. So a CAR is a recombinant antigen receptor that is comprised of an extracellular antigen binding domain, and it's linked to one or various intracellular signaling domains. And once transduced into a T-cell, ligation of the CAR by its cognate antigen can result in target cell expressing cell death. Our lab is currently developing these therapies for AML. However, AML remains a challenge, and which is distinct from B-cell malignancies. AML is really antigenically heterogeneous, even within the individual patient. And this can lead to a phenomenon known as antigen-negative relapse. Indeed, some of the preliminary work produced in our lab showed that NSG mice that were engrafted with an AML cell line and treated with CD33-directed CAR T cells eventually showed a CD33 negative relapse phenotype. Therefore, if we're to make any progress in this field, overcoming or developing strategies to overcome antigen negative relapse are critical. Recently, the phenomenon of antigen negative killing or bystander killing has been described, in which antigen-specific T cells can indeed lyse antigen-negative tumor cells, but only in the presence of antigen-expressing tumor cells. This is highlighted in the green circle in the middle. The mechanisms are still being worked out, but TNF signaling is thought to play a significant role. Some of my preliminary work in the lab involved knocking out TNF receptors in a CD33 negative cell line. And what you can see here is that knockout of the TNF receptor can indeed reduce the effectiveness of antigen negative killing as seen on the right, although this is incomplete, suggesting that there are possibly other mechanisms involved, particularly in AML. And so my current project involves characterizing the mechanisms of resistance to CAR T-cell mediated killing of antigen negative tumor. And the first aim is to identify genes whose disruption contributes to the resistance of CD33 negative AML to antigen negative killing triggered by CAR T-cell therapy. So the key experiment for this involves a genome-wide CRISPR screen that I've been developing over the last year. we were transducing Cas9 expressing CD33 negative AML cells with a library of sgRNAs to knock out individual genes. This would be one gene per cell, and then subsequently subjecting them to an antigen negative killing assay. With this, as you can see, resistant phenotypes will persist and subsequently emerge, and these can be analyzed and subsequently taken to develop novel therapies to increase antigen negative killing. And the second aim is to determine if CD33 induced antigen negative killing can be increased by augmenting TNF alpha signaling. The key experiment here would be to perform an in vitro drug screen utilizing a count-based flow cytometry assay that I developed over the last year, and which has now been optimized to detect T cells, target cells, and to quantify antigen negative killing. These experiments are currently ongoing, and I'm excited to review the results this fall. So the importance of the experience, TNF alpha augmentation can prove to be a viable strategy to improve AML clearance with the CD33 directed CAR T cells. And this may also prove as a model for targeting of other antigenically heterogeneous malignancies. With our CRISPR screen, candidate genes and pathways can inspire other novel cell drug combinations or cellular engineering strategies that may be unique to AML, but may still be critical to the success of CAR T-cell therapy for this disease. And finally, this CRISPR platform will be critical for my career development as it can be repurposed to assess other determinants of CAR T-cell efficacy, which include genes that impact antigen positive killing, or otherwise influence clonal expansion and persistence of CAR T cells. So with that, I'd like to thank all of my funders, my fantastic mentorship team. I wouldn't be here without them, program leadership, my co-fellows, and everyone in the Turtle Lab, particularly Sam Fiorenza, Duane Fee, and Hennedy, who work closely with me on this project.
Okay, thank you, Erik. That was very nice, and we look forward to your development in the CAR T cell world. So that's great. And so once again, I remind people they do have questions for our speakers. Please put it in the chat. They're being monitored by Dr. King, and she will address those questions to the speakers at the end, at the conclusion of the 5 speakers' presentations. Our next speaker is Dr. Helen Stankiewicz-Carita. Dr. Carita is in the Division of Allergy and Infectious Diseases. And Helen, you have the floor.
Great. Thank you so much. And thank you to the organizers for the opportunity to present today. Just want to make sure this is advancing. Okay, great. And I would like to start by sharing a little bit about my background. I was born and raised in Paraguay. This is a country where the culture from our indigenous ancestors, the Guaraníes, remains widely influential. And in fact, Paraguay is the only bilingual country in our continent where the indigenous language has survived and thrived. So most people will speak the indigenous language than the adopted Spanish language. So, and I grew up volunteering, providing basic medical care to indigenous children in our community, and decided to study medicine and was awarded with a scholarship to study in Argentina. In 2010, I moved to the US and completed my internal medicine residency in Chicago, and was very grateful to match at the UW Infectious Diseases program in 2015, where I also had the opportunity to complete my master in epidemiology. I was also honored to meet Dr. Anna Walt, who has been my mentor just basically in every aspect of my professional and personal life. And clinically, I attend the solid organ transplant infectious diseases inpatient service, and I also attend the HIV and anal dysplasia clinics at Harborview. And my current research continues to be a blend of studying prevention of HPV cancers, and of course now some COVID clinical research, and most recently implementation and community-based research to improve minority health. And I would like to share some of the projects that I'm working in. I joined Dr. Walt's group when she was awarded with an R01 for a randomized clinical trial to evaluate if the prophylactic HPV vaccine can reduce recurrent lesions from the vulvar or anal sites. And Dr. Margaret Madeline from the Fred Hutch is a co-PI in this grant. And I crashed as a second-year fellow, and my role has been organizing in implementing the trial, and also performing some of the procedures for the study. So just to give you a little bit of background, we do know that HPV plays a major role in anal and vulvar cancer, which are both increasing in the general population. And we treat these pre-malignant lesions with ablative therapy, so surgical therapy, because we don't have antiviral therapy directed to HPV. So we observe a high rate of recurrent lesions in these patients after they receive treatment. So the hypothesis of this trial is that the current HPV vaccine will decrease the recurrence of these lesions if we vaccinate after we ablate or treat that prevalent infection. And so that's why these participants can enter the study if they have a prior high-grade anal or vulvar lesion and no lesions at the point of entry. And we perform high-resolution anoscopy and vulvoscopy to confirm that. And then we randomize them to either Gardasil 9 or placebo, and then we follow them over time to look for recurrent lesions, which is the study endpoint. So this trial is still ongoing, and we unfortunately had a lower than expected enrollment rate because about 50% of these participants are still having a high-grade lesion after their treatment. So therefore, they don't qualify for the trial. So I received a diversity supplement award from NCI to assess the HPV viral dynamics in these patients that are receiving the ablative therapy. So I basically asked participants if they can collect a vulvar or anal swab depending on where the lesion is located. So they collect these weekly swabs 4 weeks before treatment and then 8 weeks after treatment. And then I test those as mucosal swabs for HPV detection. And here you can see as an example of 2 participants from the study, and we basically observed persistent oncogenic HPV detection after treatment of these lesions. So likely these, we're not doing a great job with our ablation for treatment for HPV, and clearly this indicates that we need better treatments for prevalent HPV infections. But most importantly, we do need to do better vaccinating our teenagers with our highly efficacious HPV vaccines before they are exposed to the virus. And unfortunately, many of these efforts are currently limited because there's a huge global shortage of the HPV vaccine. And this is particularly worrisome in low and middle income countries where HPV cancer is the leading cause of death, particularly in women. And we're currently using a 2 or 3 dose vaccine series, but there are new preliminary data showing that a single dose could be protective, and proper trials are ongoing at the moment. But another approach is if we can use a fractional dose of the vaccine provided intradermally, so in an area where it's rich with antigen presenting cells, and support the hypothesis that if we use that fractional dose intradermally, we should induce a response that is equivalent to the standard intramuscular dose. and perhaps expand that vaccine supply. And I'm currently evaluating the immunogenicity of the fractional bivalent and non-bivalent vaccine in persons who never received the vaccination. And for this study, I'm collecting blood pre-vaccine, and then in month 6 and 12 after the vaccination with a fractional intradermal dose of the vaccines. And I'm working with Dr. Juan Barnabas, also with Dr. Denise Galloway, who is testing for HPV antibodies in those samples on a Luminex platform. And of course, Anna is also a mentor in this project. And I want to share this plot that is showing that HPV 16 and 18 antibody detection. This is pre and post vaccination at 1 month. And as you can see, this single intradermal dose elicited a significant antibody response to the presented antigens. So I recently received an award to expand this project and enroll more participants. And hopefully my goal is to compare the antibody data from this project to those antibody data from the standard dose vaccine trials. Of course, COVID also happened in our life, and this pandemic has been very challenging for all of us, but personally, this also brought several opportunities for my professional growth. And I was the lead site PI for the hydroxychloroquine for SARS-CoV-2 post-exposure prophylaxis study, and co-PI for the hydroxychloroquine with or without azithromycin for early treatment of SARS-CoV-2 infection. I work with Juan Barnabas and Christine Johnston in these two studies, and who were the main PI for these multi-center studies. And we are now continue this work evaluating post-acute sequela of COVID-19 in these participants. And I'm also working with Dr. Scott McClellan on a phase 3 vaccine, COVID vaccine trial at our UDA vaccine treatment and evaluation unit, which is a site that established a partnership with the Lami and Nuxalk tribes for their participation in the COVID vaccine trials. And my goal is to expand my research skills and also continue working alongside with the indigenous community through my K23 project. And I do plan to evaluate the effect of the pandemic on the care delivery of chronic diseases in these communities. And I do hope to gather data to inform the planning and optimizing the healthcare delivery in preparation for any future healthcare disruption. My ultimate goal for all these projects and career trajectory is really just to stretch our current resources to provide evidence-based preventive and treatment services to those who may not have access, and ultimately improve the community, the health of the community. And with that, I would like to thank you, the Department of Medicine, for this award. Thank you to all my mentors, my team at the Virology Research Clinic, and thank you for your attention.
Okay, thank you, Helen. Nice presentation, nice review of your work. And now we'll move on to our fifth awardee, and our fifth awardee is Kennedy Ukadike. And Kennedy is in the Division of Rheumatology. And so I turn over the podium to Kennedy.
Thank you, Conrad. Hello. Thank you guys for attending the grand round to hear our talks today. First, I just want to say I really appreciate the Department of Medicine for the DADSER Award and giving us the opportunity to showcase our various projects. And it's pretty nice to hear all the fascinating work that everyone is doing. It's great work. So this is, you see the topic of my work, my presentation today in the Division of Rheumatology. My mentor it's Dr. Thomas Mostelin, who is the now the division interim division head. So my interest in rheumatology and actually in our lab, in Mostelin lab, overall interest, it's on elucidating the upstream initiators and drivers of autoimmunity in lupus, RA, and other autoimmune diseases. And that's really the premise of everything I do here and what I'm going to share with you today. So just starting out with some background. Complete sequencing of the human genome revealed that approximately 50% of it consists of sequences of retroviral origin. And of this, about 20%, it's the line 1 or long interspersed nuclear element. And these elements are retrotransposons, sometimes known as jumping genes or parasitic DNA. They are, for the most part, inactive in the genome, controlled by our innate genomic defense mechanisms, heavy methylation, epigenetic control. However, some of them are still active and under permissive conditions can lead to autoimmune conditions and other human diseases, malignancies, and so on and so forth. And our hypothesis is that this line 1 is a potential source of aberrant cytosolic DNA and autoantigens that can trigger trigger the innate and adaptive immune system, leading to autoimmune disease. So just to give you sort of an overview of what the distribution looks like in the genome. So there's the different classes of transposable elements in the human genomes, or retrotransposons, and their percentages. And as I already indicated, this is the focus for our project. So this particular element, it encodes 2 proteins from the 2 open reading frames that you see there, ORF1 and 2. And the first one is an RNA binding protein. And the second, the ORF2, it's an endonuclease and also has a reverse transcriptase activity, which it uses to facilitate the propagation and reintegration of these genomic materials into the human genome. And so as I indicated, based on this, it serves as a source of DNA and proteins that are autoantigens that can cause problems. So here, the core aims of my project here to demonstrate the presence of autoantibodies against the line 1 protein and also some of its associated proteins. Aim to demonstrate how this actually leads to the pathway to inflammation, interferon production, which is a hallmark of lupus. And 3 is to see if we can actually block this protein, the reverse transcriptase or RF2P from Lyme 1, to block it and potentially halt the progression or perhaps the initiation of the SLE in the first place. And precedence for this comes from a number of papers that have demonstrated that HIV reverse transcriptase inhibitors are actually able to suppress line 1 activity and type 1 interferon production. So going on to some of the data that we have. So we have detected autoantibodies in SLE patients and also some other disease controls and healthy controls. But the thing here that's striking is that the IgG anti P40 or anti-Lyme 1 antibodies are consistently more significantly elevated in pediatric, both adult and pediatric SLE compared to other disease type. And these correlate with, many of the markers of disease activity in lupus. So that it's a really interesting finding here. And we've also demonstrated that the protein, the P40 protein, that from that first open reading frame of line 1, it's actually expressed in immune cells, but predominantly in neutrophils. And that's demonstrated here, neutrophils from SLE patients. So it's demonstrated in the Western blot. So we've detected the protein. And also we've demonstrated this by RT-qPCR, detecting the mRNA of line 1 in neutrophils much more than lymphocytes. And then we've gone on to test this theory of inhibiting the reverse transcriptase in lupus. And so we get neutrophils and treat them with these reverse transcriptase inhibitors. That's emtricitabine and tenofovir alafenamide. It's a combination drug known as Descovy. So what we have done, so after treatment, we do the qPCR, and we are able to detect, the signal that there is decreased expression of these interferon-inducible genes. So these genes tend to be elevated as a surrogate for interferon beta expression, for example, in cases of inflammation in SLE patients. So with treatment, this is the levels are actually lower, which indicates that there is some blunting of the inflammatory process that's going on there. So overall, we have demonstrated that adult and pediatric SLE patients have autoantibodies against line 1 proteins, and that the levels correlate with disease activities and various markers in SLE, and that the proteins from line 1 are predominantly expressed in SLE neutrophils, and their levels again correlate with disease activity. And treatment of the neutrophils with HIV reverse transcriptase inhibitors cause reductions in the interferon beta and interferon signature genes. And this preliminary data, again, provides additional evidence for potential use of the RT inhibitors for treatment of SLE. And so there is, a number of ongoing work on this project that I've shared with you, in detecting other autoantibodies in RNA-seq and testing the SLE inducing agents, and more detection of the interferons and interferon signature genes. And ultimately, the goal here is to accumulate enough or sufficient data to support our goal of eventually conducting a small phase 2 clinical trial of HIV reverse transcriptase inhibitors for the treatment of lupus. And this couldn't have been possible without all the help and support that I've gotten from my mentor, Dr. Mustelin, the Division of Rheumatology, our collaborators, and of course, again, I appreciate the DATSA award from the Department of Medicine. Thank you, guys.
Thank you, Dr. Ukadike. Very interesting work, and I want to extend my congratulations to all 5 of the award winners. The Department of Medicine is proud to support, in our DEI efforts, your faculty development. We think this is a major component of our efforts to promote DEI efforts within the Department of Medicine. As I said during the course of your talks, Dr. King was monitoring the chat function, and I'll turn it over to Dr. King now to pose any questions that may have come up.
All right. Thank you so much, you guys, for those excellent talks. I will just call out some questions. I know some of you have put some answers in, but just so the whole audience, we've got over 50 people listening, so just so everyone can hear your responses. This first question is for Chase, and the question was really about the volume, about your home blood sampler device and what volume you can get with it, and how you store it, and how long patients have to turn the device back in.
Yeah, thanks. So the pilot study that we did was using one of their earlier versions. And so that had a proprietary tube on it that was expected to be about 500 to 600 microliters total of blood if you just used one device. And so when you spin whole blood down, obviously all of that is not used if you were doing serum tests. So it was about half that. So we actually had people use a couple of devices for us to be confident we had all the volume we needed for the testing we needed. And so the RCT will have actually a newer generation device that gets double that amount of volume. So we should hopefully not have that volume issue. And the time to turn in the test depends on the test, but these samples will be shipped sort of ambient temperature. And so we know for sure for gonorrhea, chlamydia swabs that's okay. We don't know exactly for sure on this, although it's been done for COVID antibody testing and seems to be okay. We'll have to see as we get started.
Great, thanks so much. And our second question here is for Crystal. And this is a question sort of for the providers in the audience. The question is curious about what we can do as providers to help minorities with their concerns about bias when directing towards appropriate end-of-life care. Does kind of knowing this is not a simple answer, but just looking for any perspective you have on this.
Yeah, so a couple of things come to mind. So first of all, I think one big issue is rapport with the patient. So it's not just what you say, it's how you say it. There's data in the literature that suggests that even when physicians are having conversations with Black patients at the end of life, there's still overtones of bias, and that's shown in the tone of their voice or how they're sitting with the patient or other types of body language. So it's not just what you say, it's also how you say it. And then second of all, I would say that one thing that has come up a lot in ethics consults is feeling rushed or pressured to make a decision that's around end-of-life care. So whether or not patients or families feel like they're not, haven't gotten assurance that all their options have been explored before recommending a change in code status or the withholding of life-sustaining therapies or feeling rushed to make decisions. So those are the two things that come to mind. And of course, the answer is much more complicated than that.
Excellent. Thanks so much for that reply. I see there are a lot of comments in here, just thanking all of you guys for your great work. Really excited to see where all of you are going. And I don't see any further questions here.
Well, I want to once again thank all the awardees. I was very impressed. These were DEI. This is a DEI-based award system, but I was really impressed with the diversity and breadth of the research. I mean, it really covered wide areas of research. It's not all oriented in one thing. It just shows the diversity and the breadth of research that we have in young trainees and young faculty in the Department of Medicine. So thank you very much for your presentations and congratulations.
Thank you.
Thank you.
Thank you.
Thank you, Conrad. Thank you, everyone.
And thank you for the audience, for attending these grand rounds. And grand rounds will now occur basically every week at Friday from 12 to 1. So see you next week. Thank you.